That's a very, very difficult presentation to follow. Thanks very much. That was inspirational. For someone, I've been in the industry 13 years, albeit in a different sector, but that really was inspirational. It was kind of fired me up and got me thinking about where I'm at. I'm presenting on a study that I did as part of an MA in healthcare management last year. I was looking into I was investigating the adequacy of special seating service provision in Ireland. And that very last slide shown there epitomises what it is we do. We customise wheelchairs for children and adults with very, very special needs, very, very high level physical requirements. We're one of only two, there will be two centres doing what we do, and I'll get into that now. There will be other centres as well doing it to a slightly lesser degree. So what I was trying to do was to assess the adequacy of the provision of such services across the country. Now, so what I'm going to look at is background to the work, the research hypothesis, purpose and objectives of the work, methodology, results, conclusions, and recommendations. The background is that I work for Enable Ireland, Disability Services Organisation. We've 1,200 staff working in the organisation, providing services to children and families of children with physical disabilities and to adults with physical disabilities. The whole disability landscape is changing now with the merging of organisations, so it won't be as clear-cut as in time to come. With the special seating department, as I said, there are 1,200 in Enable Ireland staff. There are only 10 in the seating department, so we're very much a niche department within the larger organisation. We custom manufacture special seats and fit them to wheelchairs. And again, a wheelchair could be something very basic that you would be familiar with seeing, up to, on a manual level, more complex, that's termed a tilted space wheelchair. In other words, the position of the chair reorients itself in space for comfort and pressure management purposes. And similarly, with powered mobility, you have very simplistic powered wheelchairs up to very complex powered wheelchairs. But our focus is on having people select and prescribe their wheelchairs, but specifically our area is the special seating. So in this particular example, it's a custom contoured system, so it's custom molded to match the person's exact physical presentation. Now, in doing that, there'll be clinical input. I work as a clinical engineer, so I'm working in the clinical environment directly with the end user, and I work with a team of physiotherapists, occupational therapists, but we work independently and we work collectively. So we'll be involved in the prescription and specification of that sort of equipment. I've been there for over 10 years, and in 2011 I started an MA in healthcare management, and this dissertation came out of that. And what I wanted to do was explore perceptions, my own and others, in relation to special seating provision. So the research hypothesis was that there exists an inequitable level of special seating service provision across Ireland. And my perception at the start was that seating services such as ours had grown in an ad hoc fashion. There were two main providers, the Central Media Clinic and ourselves, Enable Ireland, a mix of public, private and voluntary organisations. There are scattered services, and services often work in isolation from each other. So this is the seating landscape, and this is a map showing Enable Ireland and CRC centres around the country. What we have then is we provide our seating service in Sandymount, and we have outreach clinics in Tallaght, Kildare and Bray, County Wicklow. The CRC provides their seating service from Clontarf, and they have outreach clinics in Tallaght, in Scunthorcua, sorry. And that is how the eastern region is actively covered. The CRC also have an outreach centre covering the kind of Waterford-Kilkenny area, and they have another service based in Limerick. We provide an outreach service to Kerry, and in Cork, Enable Ireland provides an element of seating, but it doesn't have the technical support that all the other centres that I've outlined would have. Concurrent with that, the HSE runs an element of seating service provision in Cork, but again without the technical engineering input. Similarly in Galway, the HSE runs a service, and then you've got three main private providers, one Dublin-based, one Cork-based, and one Sligo-based. So that is effectively the landscape. And as you can see, as I mentioned in the last slide, it's rather scattered, ad hoc, and isolated. So the objectives were first to identify the need for wheelchair and special seating, secondly to determine the adequacy, and thirdly to investigate interregional variability. The research limitations were significant. It was just a 14-week dissertation period. It was a minor dissertation. There's a severe lack of published data in the area. The sampling was a convenient sample based upon people who had taken training in this area provided by ourselves over a 10-year period. So basically, the questionnaire was sent out to students, former students of that course. There was a sampling bias. There was underrepresentation of certain regions, so we got a good bit more feedback from areas closer to Dublin than it did further away, so that affects the results. And it was a proxy sample, so I was asking people about the adequacy of service provision, but the people I was asking were service providers themselves, so I was asking healthcare professionals to answer in effect on behalf of end users. Not all the data came back was complete, and previous work had focused on outputs rather than effectiveness, and I was doing that as well in this work, as we're looking at outputs rather than the effectiveness of the service provision. So that whole area of outcome measures is a big area and a growing area, but one that hasn't been adequately explored. So I'm sorry my slides are busy. I have done them as bullet points or with animation, but it's not working on the screen, so I can move that. So they're coming up quite busy. But in estimating the need, what I did is I looked at national estimates and correlated this internationally. I looked at supply based on the available data, the National Physical and Sensory Disability Database, Department of Logistics and Inventory Management within the HSE, and my questionnaire that I rolled out as part of the research. And in assessing the adequacy, I used the questionnaire. As I mentioned, it was a convenient sample, and it was based on therapists with training and experience in WSAT is a short term for wheelchair and seating assistive technology, so it's kind of a global term for covering both wheelchairs and seating. So the estimates then, I come up with various different estimates from different sources. And the estimates would be that the percentage of population with disability worldwide is given in the order of 10 to 15%, US research 13 to 20%, and Ireland 10 to 20%. You're getting the ballpark. So I took a 10% figure for the purpose of this research. The percentage of the population needing a wheelchair then was effectively 10% of those with disability. So that brought us down to this value of 1%. The other important piece is that this figure is likely to increase as the aging population increases and dependency increases with longevity. So that was wheelchairs. Looking at special seating, which is the area of interest, and based on National Physical and Sensory Disability Database, I come up with a figure of 13,500 people requiring something above and beyond your bog standard out-of-the-box wheelchair. Based on HSE spending, and this was a significant assumption, but what I did was I based spending on seating against spending on wheelchair and come up with a 44% requirement of additional seating supports on top of wheelchair spending. And again, that was a proxy measure, so it was a bit of a leap of faith. I had done an MHSC in 2001 following a degree looking at wheelchair design, and as part of that I did some market research, and as part of that I had come up with a figure of 24,500 requirement. And CSO figures from Census 2010, I think, come up with a figure of 26,000. So we're talking about a figure somewhere between 15 and 26,000 people in the country requiring special seating adaptation in order to sit in their wheelchair. Many of them would do so for 8, 10 or 12 hours a day. Now many of us here sitting today looking around the room, people are shifting, people are folding their arms, crossing legs and crossing backwards and forwards. It's very difficult to sit for a long period of time in one position. So when we're talking about special seating, that is what we're talking about. It's about enabling people to function optimally by providing them with appropriate seating given their circumstances of being sitting for 8, 10 or 12 hours. Think of the longest long-haul flight you've ever taken, a 12-hour Singaporean or Los Angeles long-haul flight. And imagine repeating that every day. So that's what we're talking about here in terms of our 26,000 people. So then using census figures, broke that down to highlight the regional requirements for special seating. So in summary, we have about 40,000 wheelchair users in Ireland, of whom about 27,000, up to 27,000 need modifications, adaptations to their wheelchairs. So to investigate the adequacy of this, I devised a questionnaire, the self-completion questionnaire. I piloted it with the Irish Postural Mobility Network, that's an interest group in the area committee. Circulated it by email with a cover letter and used as a convenient sample. The sample was 131 people and a response of 41 or 31% response rate, and it provided quantitative and qualitative feedback. The regional representation, as I highlighted, was very much higher in the Dublin Mid-Leinster, Dublin North East area as compared to the West or the HSE South areas. But what came back was that of 1,500 people nationally identified as needing, within the sample, as needing special seating requirements, about 1,000 or 2/3 of those were getting them. So about a 66% level of service provision. The providers vary: HSE, voluntary, that'll be ourselves in the CRC, so Enable Ireland and CRC, and private. So that's the breakdown of the people, the companies, the organisations that are providing these services. This is the stark finding. The level of service provision varied hugely depending on what part of the country you lived in. So the postcode lottery aspect. So in the Dublin regions, and I grouped for functional purposes, I grouped Dublin North East and Dublin Mid Leinster together. So 95% of those identified as needing services were getting them. In the West, we were talking 43%, and in the South, we were talking 1 in 3. So nationally, special seeking services are provided to about 2/3 of those identified as needing them, and the figure varies across HSE areas, highest in areas closest to Dublin and lowest to the south. Is special seeking service provision adequate? People are getting it, but is it perceived as being adequate? Yes in 50%, 57% of cases globally, no in 43%. But again, we see this discrepancy. Yes in 2/3 of cases in the Dublin areas, and no in 2/3 of cases, or in 57% of cases in the south. So again, disparity in terms of the quality and fairness of service provision. There are various aspects of special seeking services, and they would include assessment for need, design and manufacture of bespoke equipment, which would be following along the lines, and at a much more basic level, but following along the lines of what was presented earlier. Seeking modifications for individual service users, and specialist advice on off-the-shelf seeking solutions, the things that can be got out of a box. So again, different levels of access to different aspects of this, but this would be the one that requires specialist technical expertise, clinical engineering technicians working in this area. And again, we see the discrepancy between the Dublin areas and the south. And I'm skipping the west because it falls in between, so I'm just that's why I'm showing these two as the extremes. So again, a higher level of provision in the Dublin regions. What is interesting is if we look at the regional comparison of money spent on wheelchairs and special seating per capita. So on the left, in the blue columns and purple columns, you have the wheelchair spending, and in the right columns, you have the seating spending. So there seems to be, if you look at these charts, there seems to be a correlation between the level of spending and the perceived adequacy in the provision of services. So, in summary, overall perceived adequacy of services is in the order of 57%. It's highest in the Dublin region and lowest in the south. And there are variations in service provision and access to the various elements of special seating services, and these appear to correlate with the regional variations in HSE spending. And I must emphasise this on new wheelchair seating system technologies. There is a recycling piece of work ongoing at the HSE at the moment. It's unclear that the information isn't mineable from that information yet. So this is based on the new spending. So in terms of the qualitative feedback, the main themes were waiting times for the prescription, delivery and provision of special seating, funding and resources for special seating services, localisation of service delivery. In other words, people having to travel distances to receive their service. So there is this argument for centres of excellence, and yet people want to have their service closer to home. And the recent development in progressive disability services for children is doing that. It's moving services closer to home. Training needed for all stakeholders. So this would include clinicians practicing, prescribing equipment, families, users of equipment, etc., etc. And standards of practice need to identify best practice in the area. So in conclusion, there is an apparent inequity in the level of special seating service provision across Ireland, notwithstanding, as I said at the start, the limitations of the study. There appears to be a correlation between the level of service provision and HSE spending on wheelchairs and seating assistive technologies, and there appears to be a correlation between perceived adequacy of services and HSE spending on wheelchairs and seating. So the recommendation would be that there should be a consistent level of adequacy across regions. There is a critical mass identified that has been in the literature for these sort of services, and they're saying the order of 500,000 to 1 million population, so one specialist seating service per 500,000 to 1 million population. The recommendations for regional seating services with multidisciplinary teams, so clinical engineering, physiotherapy, occupational therapy, working together, working to common standards of practice, and providing support to primary care teams and networks at local level in line with primary care strategy. And there's a need for adequate infrastructure. So this stuff just doesn't happen itself. There needs to be equipment provided, machinery, machine tools to manufacture and materials to manufacture the equipment. So this is the HSE's primary care strategy and progressive disability services initiative. And they promote this notion of primary care teams supported by what they would refer to now as disability network teams. And then the disability network teams in turn need to be supported by specialist services, and we will see special seating fitting in this sector. So, final slide is, if you like, my vision of for the future of these services. And I would suggest that we work with what we have. We have two major services north and south of Dublin, and we have services in Cork and Galway and Sligo. So if the country could be kind of divided up into 4 regions and services be targeted primary centres, so if we come to this million, half a million to million critical mass of population, we could have services that operate in these areas, and then we could have satellite or outreach clinics and in locations and crossover and greater communication between these services if they shared service provision in these areas. Then you're going to have, there are already established centres elsewhere, and then you're going to have the outliers, if you like, if that's a fair enough term to use, with the likes of Letterkenny, Kenny and Kerry, which again, like being served from Cork, it's still a good distance, or being served from Sligo, it's still a good distance. So to establish outreach, an outreach clinic is where a service moves from its primary base of service provision to a centre and provides a clinic every month or every second month. So that would be, as I say, a proposal for our revision. So thank you very much.